it already, and I was pleased to see a couple of weeks ago President Obama announced a very similar prize of $15 million for a rapid diagnostic to beat AMR. So we're all in business, and I really think it will make a difference. I think genomics is central to how we go forward in this area, typing organisms, determining treatment, mapping outbreaks. So I thought I'd show you two particular British examples of this, both published in The Lancet last year. The first is a TB example from Oxford, where using whole genome sequencing of the TB genome, they can apply field epidemiology. And it's a complex slide, but the bubbles on the top left are the genetic tree. The matrix on the right shows you the variations in nucleotides, so the ACGT of the DNA, and you can see how it changes. The bits on the bottom left show you the family linkages by colour, and there are 4, the very bottom one, P066, and then the other 3 in the same blue with a blue circle around them that have no family link. We wouldn't have known that without the genome sequencing. Very interesting. And then that right-hand bottom column shows you the individual patients and where they were dark, they were symptomatic, where it's pale, they were on treatment, and it shows how their sputum and their TB changed, red being active, white being you couldn't pick it up. So that shows you how genome sequencing of TB can tell you where it comes from, where it moves to, how it mutates, and how it goes. And a key component of this analysis was the estimation of that molecular clock and how you can distinguish between patients in different ways. So that's Oxford and TB. This is just to be a nice balance. Cambridge and MRSA. And this was the investigation of a new, seemingly restricted MRSA outbreak in the Cambridge Special Care Baby Unit of MRSA. And the grey bits, blocks, are where there were no infections. And what actually this work shows is how they were all linked despite the absence of an ongoing obvious transmission change. And actually, what the sequence shows is that a staff member was a carrier that was very important. And it just shows you how they move round. And in this slide, what you can see at the center of it is it's a phylogenetic tree of all the cases, and there are 20 individual colonies from a staff member, and the staff member was in red. And you can see how it changed and mutated from person to person and how it happened. And the H red ones are the healthcare workers. So very interesting way of using speedily whole genome sequencing of a bug to show you who's infecting whom and how it moves around. Now, at the moment, that's not cheap, but it will become cheap, and it gives us handles on disease outbreaks that we didn't have before. To go back to my theme of antimicrobial resistance, more generally, though, we're going to have to do some things about sanitation, hygiene, improve the speed of diagnosis, make sure everyone understands, not just in the human sector, but this is a One Health agenda, but animal keepers, the importance of getting this right, and we're going to have to improve our surveillance and monitoring and everything internationally. I realise I'm going on rather a long time, so I'm going to speed up a little bit on some of this, and I've talked to you about the global level and what we're doing, working there, and I've also talked to you to a large extent about what we've done already. I just want, before I finish, to talk more generally about genomics and public health. And in 2012, I was asked by the then Chief Executive of the NHS, what were my priorities, as I was expert at genomics and he wasn't, for the NHS. And these were the priorities I gave him. I'm sorry to say that at the time he ignored me, but the new Chief Executive asked me again, so I sent it to him and said, I don't think it's changed, except we now have a priority of delivering a new project on whole genome sequencing. So why would we want to do whole genome sequencing? That is not just looking at little alterations across the whole of people's genome, looking for disease or risk factors, but scanning the whole genome. Well, it's because we're going to get much more information. So we have a project co-funded by ourselves and the Wellcome Trust, Deciphering Developmental Disorders, DDD, that found that if you did a good scan of the coding part, the exome, you could get a 30% hit rate of diagnosis for rare diseases. But then, from Nijmegen, the Dutch showed that they could up the diagnosis rate when they looked at the non-coding part, when they looked at the whole genome. And when I tell my colleagues about this, they say, but if you can't do anything about it, does it really matter? And you only have to know some of these families, and I remember some of these families from when I started training as a paediatrician. People want to know a diagnosis because they want to know whether they can have prenatal diagnosis. They want to know it's not in their mind and made up, that it's real. It helps. And we really should try and find out. The other fascinating thing is if you find a diagnosis through DNA, then the next thing to do is to have a look at what biochemical pathways that works in. And you may well find that it's in a pathway where there are drugs already, but no one thought to use them in this rare congenital inherited disorder. So there's hope too. And then there's this work from Canada, which I thought you'd be quite interested in too, carrying out exome sequencing, and you will know more about that than us. So I was extraordinarily pleased, though I clearly knew it was coming, when one of our shared compatriots, Sir John Bell, persuaded the Prime Minister to make an announcement that we would sequence 100,000 patients' whole genomes, the 100,000 project. This was December the 10th, 2012, so not that long ago. And the objective of saying this was to take on a real science challenge for us, you know, a bit like going to the moon. Can we do it? What would it show? Trying to also keep Britain, where we are one of those countries at the forefront of genetic research, genomics research, keep us at the translation of it into patient care. And can we, as we do this, move the NHS, that great tanker, the biggest employer after the Chinese Red Army, into a genomic era? Can we do it? Well, when the Prime Minister announces something, you have to do it. And we're going about this in an entirely novel way. Because there wasn't much action for a few months, then persuaded the government that the only way to do this was to take it away from bureaucrats. And that what we needed was a startup company. So we have set up a startup company. It's called Genomics England. There is only one shareholder, the Department of Health. I represent the shareholder on the board. We have an executive chairman who has run startups. And we have a former finance director from a major pharma. We have a proper board as a startup, and we're running it as a startup. And it's proving very exciting. And actually, do you know, we're going to manage it. So, what are the challenges? Well, there is a sequencing challenge. not there was, which is partly a cost challenge. When the Prime Minister announced it, a whole genome was costing £6,000 a scan. I can't tell you what it's costing now, though I think I was told. Well, of course I was told, I'm on the board. And the Treasury signed it off too. That tells you something interesting. But we have just signed a partnership agreement with Illumina for their newest machines. We're setting up a sequencing centre on the Sanger Institute site at an affordable price. So, and no bureaucrat would have ever managed to do that deal and make that happen. There's a data challenge, because not only do we want the data from the genomes, but we need, and every patient's consenting to join in, we need all their clinical data. And though there are data systems in the NHS, they're not linked up in general. So that's a very interesting one. There's a security challenge, privacy and confidentiality. And the executive chair has come up with the most wonderful metaphor. We are setting up a reading library, not a lending library. So people who want to use this will have to get ethics committee permission, they will have to go to an access committee, but they will also have to come into the database to use it and only be able to take the results out, not the patient data. Meanwhile, because it's our database, we'll know exactly where they went and did they stick to what they were told they could do. And if they don't, it's a criminal offence, so we'll lock them up. And I will too, because the Prime Minister, in announcing it, gave me, as Chief Medical Officer, the right to stop this project if I believe that the data is at risk. It is terribly important to us to get this right. There is the challenge of clinical interpretation. And so we're setting up, in partnership with the Wellcome Trust, the British Heart Foundation, Cancer Research UK, all sorts of people, a clinical interpretation partnership, so people can come in with grants from all these people, interrogate the data, interpret it, put what they've found into it, and get their publications and everything. It's that reading library. And then, of course, there's the supply of samples from the NHS. That's a logistics challenge. So we're getting logistics people onto it. And finally, the NHS getting results back. Well, for the rare diseases, the clinical geneticists and paediatricians are pretty genomic sensitive, so we think that'll work quite well, and the experts will explain it. For cancer, they're way ahead in this game, and I don't see a problem. But as we extend into other areas, we will have to take great swathes of clinicians and people with us who haven't previously been genomically trained. And so we have a big education program going on, just starting. And then, of course, there's, do we feed back incidental findings? So we have both a scientific committee chaired by Sir John Bell and an ethics committee debating what we can safely feed back. And even I, who am reasonably genomic literate, am surprised at how much is not known about a lot of genes we've heard a lot about. It is a research program, so we're not offering to feed anything back except the specific cancer and rare disease, but we're looking at the other things, and we will set our rules for that using this work between the Science Committee and the Ethics Committee that will hold for England and will not be the same as the US rules. To get patients into this, we're using the National Institute of Health Research bioresource as the pilots, and I set up the NIHR and still lead this, and we have this massive bioresource of healthy volunteers and patients who've provided samples already, provided consent to access their clinical records and to do studies. And we have